Good evening, ladies and gentlemen. It is a pleasure and honor to be sharing with you this presentation. I thank Dr. Amal Bishlawi for inviting me, and I thank Novartis for allowing me to discuss emerging therapies in sickle cell disease. My name is Dr. Mervat Mattar. So regarding the pathophysiology of vaso-occlusive crises in sickle cell disease, these are the #1 cause of hospitalization because of pain and because of infarct in sickle cell disease patients. And these cause real problems to our patients. And so the mechanism of vaso-occlusive disease is complex. These crises happen not only because of the sickling of the red cells, but because when red cells are sickled, they demonstrate on their surface P-selectin receptors. And so they can interact with the damaged endothelium through P-selectin, L-selectin, E-selectin, and others, so that now they can attach to the endothelium. Also, the damaged endothelium attracts through its adhesive molecules some white cells together with platelets. And the interaction between these four can give clotting along with free radical release. And so on and on the clot is formed, and it can be disseminated in the body anywhere. So targeting the pathobiology of sickle cell disease, we can either target the sickle cell by trying to change the genotype by allogeneic bone marrow transplant or autologous stem cell transplant, or by targeting the hemoglobin S polymerization by increasing fetal hemoglobin, or by trying to affect the genome or the gene causing the sickle cell problem by suppressing certain elements of this gene, or by changing the gene, maybe by infection with an antivirus. And this is what is called gene therapy. Or this can be done pharmacologically, of course, by the regular hydroxyurea. We can also try to increase the oxygen affinity of the hemoglobin. Also, we can target the vaso-occlusive problem by inhibiting the adhesion and the interactions between the cells and the endothelium. Or you can target the inflammation by targeting the feedback loop of sterile inflammation that promotes further stimulation and further vaso-occlusion, for example, by L-Glutamine. Here we are going to discuss the emerging therapies of treating vaso-occlusive crises. So these are all FDA-approved treatments, hydroxyurea, which is well known, but also L-Glutamine, which affects the vaso-occlusion by decreasing the oxidative crisis inside the cell through the action on the NAD coenzyme, or by the use of the monoclonal antibody crisanilizumab, which can target vaso-occlusion by targeting the P-selectin inhibition, or Voxilator, which is an FDA-approved drug targeting the hemoglobin S polymerization, so as there is less S polymerization, less sickling and increasing oxygen affinity. Of course, there are others such as HLA-matched transplant or haploidentical transplant. So, discussing crisanilizumab, which has been FDA-approved to reduce the frequency of vaso-occlusive crises in adults and pediatric patients aged 16 years and older with sickle cell disease. Now, as we have mentioned, P-selectin contributes to the development of vaso-occlusive crises, and blockage of this interaction between the endothelium, the white cell, the sickle cell, and the platelets through inhibition of P-selectin. This can decrease the cell-cell interactions and decrease the formation of the vaso-occlusive clot. And so, crisanilizumab is a monoclonal antibody that has P-selectin inhibition properties. It is a humanized antibody, and so there are no antibodies formed against it in blood, and it has a high affinity and high specificity for P-selectin by blocking its ability to bind to its receptors, and so stopping the vaso-occlusive problem. This FDA approval was based on the SUSTAIN trial, which was a phase 2 study in cases of sickle cell disease, and this are not only pure hemoglobin SS cases, but also hemoglobin SC, hemoglobin beta thalassemia, and others were included. And these cases were between the ages of 16 to 65, and they were included and segregated to have either 2 to 4 sickle-related painful crises within the past 12 months before recruitment, or 5 to 10 sickle cell-related painful crises within the past 12 months before enrollment. The use of hydroxyurea was acceptable, taking into consideration that hydroxyurea was used in these patients 6 months before enrollment and in a stable dose for the past 3 months before enrollment. Of course, patients on long-term transfusion therapy were excluded in this case. And now the study design, patients were included 198, so this was quite a good number, and they were randomized in a 1-to-1-to-1 fashion to either receive crizanlizumab in the 2.5 milligram per kg or the 5 milligram per kg IV doses versus placebo. And these were ramped up, the dose was ramped up. They were receiving day 1 and day 14 as an intravenous 30-minute injection, and then afterwards they were receiving the same dose every 4 weeks. And this was, loading dose followed by a maintenance dose every 4 weeks for up to 52 weeks, and then the final follow-up. Now, the key study endpoints, of course, number 1 would be primary efficacy endpoint, which is the annual rate of occlusive crises within the trial period. Secondary endpoints included annual rate of days hospitalized, time to first and second vaso-occlusive crisis following the use of medication, annual rate of uncomplicated crises, annual rate of acute chest syndrome, and the brief pain inventory questionnaire. Also, they had to look at the pharmacokinetics and the pharmacodynamics of crizanlizumab, and of course, safety. Now, these are the patient characteristics, and as you can see, all types of hemoglobin S genotypes were included, not only hemoglobin SS, and some of the patients, actually most of the patients, had been receiving hydroxyurea before, and they were still included in the study. Now, most of the cases had experienced 2 to 4 crises in the past 12 months before enrollment, but some of them also experienced more than 5 up to 10 vaso-occlusive crises within the past 12 months before enrollment. Look at hemoglobin level. This was a regular hemoglobin level, so they did not need repeated blood transfusions. And let us look at the results. Now, crizanlizumab, 5 milligrams per kg, significantly decreased the frequency of vaso-occlusive crises in relation to placebo and in relation to the 2.5 milligram per kg dose. And it also decreased the vaso-occlusive crises, irrespective if the patients had been using hydroxyurea or not. In patients that were using hydroxyurea, it decreased the crises by 32%, but in patients not using hydroxyurea, it decreased the crises by 50%, which is rather astounding. And it also decreased the number of occlusive crises, whether the patient had had many crises before or less crises before. So if the patient had 2 to 4 crises before or 5 to 10 crises before, still crizanlizumab 5 milligrams per kg fared well and decreased the incidence of vaso-occlusive crises. If patients had 5 to 10, many crises before, it decreased it as less as 63%. Now, regarding the genotype, whether the patient had a hemoglobin SS or a hemoglobin S other, still crizanlizumab 5 milligrams per kg fared well, and it decreased the vaso-occlusive crises in both incidences. And so, even patients with homozygous or heterozygous hemoglobin S fared well with this medication. It also showed some additional benefit in combination with hydroxyurea. However, there is no biological basis to assume a synergistic effect when hydroxyurea is combined with the medication. How about the likelihood of event-free vaso-occlusive crises among these patients? Well, uses of the dose of 5 milligram per kg gave a high percentage of vaso-occlusive crises event-free patients. That means that patients with no events. And this was also true if the patient was receiving concomitant hydroxyurea or not receiving concomitant hydroxyurea. And this was also true if the patient had had high incidence of vaso-occlusive history or low incidence of vaso-occlusive history 12 months in the preceding 12 months before enrollment. Another astounding result was that it increased the likelihood of event-free vaso-exclusion in these patients, irrespective of the genotype, whether it was homozygous SS or Lentiglobin S among and other hemoglobinopathies. Now, whether the patient had high incidence or low incidence of vaso-occlusive history, whether the patient was receiving concomitant hydroxyurea or not, still there was an increased incidence of event-free vaso-occlusive crises among patients using crizanlizumab in orange versus placebo, which was in gray. Now, how about the time to first vaso-occlusive crisis following the start of treatment? Well, there was a lower vaso-occlusive frequency with crizanlizumab, 5 milligrams per kg, and this was very evident. Actually, this was evident as early as 2 weeks of the start of treatment, and this was maintained through to 52 weeks. That means that as of 2 weeks after the start of crizanlizumab, 5 milligrams per kg, the incidence of first vaso-occlusive crisis after the start of treatment was delayed, and the delay was maintained up to 52 weeks. This was great. That means long-term efficacy. And this was also maintained whether the patient was receiving concomitant hydroxyurea or not. And this was also maintained whether the patient was a bad occlusive crisis history, many crises before the treatment or not. And this was also maintained and observed of delayed first vaso-occlusive crisis, especially in patients with hemoglobin SS genotype, but not in other genotypes. How about the second vaso-occlusive crisis after the start of medication? Well, yes, it increased the time to second vaso-occlusive crisis regarding the 5 and also the 2.5 milligram per kg dose versus placebo, as you can see, the blue and the orange line versus the gray line. And so other efficacy endpoints, yes, the median day of hospitalization was less. It was only 4 days versus 6.87 with placebo, with a 41.8% reduction. However, this was not statistically significant. The annual rate of acute chest syndrome was rare. It was a rare incidence, and so it was 0 in all groups. The annual rate of uncomplicated pain crises were diminished with the use of crizanlizumab 5 milligrams per kg, and this was statistically significant. And so, no vaso-occlusive crises, no painful crises as of the start and the continuation of crizanlizumab 5 milligrams per kg. So, how about the PK/PD? Was the concentration of crizanlizumab maintained all over the 52 weeks? And the answer is yes. Here we have a peak of the loading dose the first 14 days, and then now we are taking it everywhere, administering the drug every 4 weeks. And as you can see, there is a maintained trough level of crizanlizumab in plasma up to 52 weeks. And there is a maintained P-selectin inhibition up to 52 weeks while the patient is receiving the medication on a regular basis. How about adverse events? Well, the frequency of adverse events was similar in the 3 groups, including the placebo group. And this was unrelated to the dose of crizanlizumab. The most frequent adverse events in crizanlizumab treated patients were pyrexia, influenza, and pneumonia. And so our conclusions, the treatment of crizanlizumab 5 milligram per kg IV was significantly reducing the frequency of pain crises in adults with sickle cell disease. And this reduction was apparent whether the patient was receiving concomitant hydroxyurea or not, whether the patient had had an increased number of crises in the previous 12 months or not, and whatever the sickle cell disease genotype was. It also achieved a sustained blockade of P-selectin in a dose-dependent manner over 52 weeks, and it was associated with a low incidence of serious adverse effects. So this was a success story in these patients with sickle cell disease, was occlusive crises, less pain, less crises. How about the next FDA-approved drug? That was L-Glutamine, which is Endari, and the mechanism is not fully understood. Probably L-Glutamine reduces the oxidative damage to red cells by improving the redox potential of NAD, which is a coenzyme. And it is formulated as a white crystalline powder and mixed immediately with a beverage and consumed before meals. It is taken orally twice daily according to body weight. It was approved in the FDA, by the FDA in July 2017 to reduce acute complications associated with sickle cell disease in patients aged more than or equal to 5 years old. And it reduced, in the phase 3 study, it reduced the cumulative number of vaso-occlusive crises by 25% versus placebo. The third FDA-approved drug is Voxilator Gbt440, and this is an aldehyde that binds to hemoglobin S, and by binding to hemoglobin increases the oxygen affinity of hemoglobin S and delays hemoglobin S polymerization in hypoxic conditions, thus prolonging the red cell half-life. It is orally bioavailable and partitions into red cells and red cell plasma ratio in a red cell plasma ratio of around 150. And so this way it can shield the red cell from being sickled in hypoxic conditions and other conditions, and thus it decreases hemoglobin S polymerization. And in phase 3 study, which is the HOPE study, it was of use in patients aged 12 to 65 years with sickle cell disease with more than or equal to 1 crisis within the last 12 months. There are others that have not yet been FDA approved, such as rivipansel, and with rivipansel, it is a pan-selectin inhibitor, specifically E, P, and L selectin inhibitor, and this way it was hypothesized that it can increase RBC velocity in the blood vessels, and so decrease its stagnation and decrease clot formation, and decrease biomarkers of adhesion, activation, and coagulation. A double-blind placebo-controlled phase 3 study was underway. However, it was terminated in 2020 because of the lack of efficacy, lack of achievement of the primary endpoint. Cevuparin is another medication. It is heparin-like or heparin-like medication, and it inhibits sickle cell erythrocyte adhesion and neutrophil adhesion to endothelial cells in vitro. It decreases vaso-occlusion and improves blood flow after tumor necrosis alpha treatment in mice. And the mode of action is that it binds to P and L selectin and others to decrease vaso-occlusion in sickle cell disease. It is still on the way, and a phase 2 study was done in patients with sickle cell disease requiring hospitalization because of acute vaso-occlusive crises. Lentiglobin is the last one, but this works in a different manner. This is one type of gene therapy. Lentiglobin uses a lentiviral vector, and it is introduced inside the lentivirus. We introduce one form of beta-globin adult gene that sort of rectifies hemoglobin S inside the human body. What happens is that we take CD34 primitive cells from the human body, autologous, and we transfect these cells in vitro with the lentivirus carrying the beta globin gene, and then we reintroduce these cells back into the body so that they can produce normal adult hemoglobin. And they try to introduce a beta globin gene with anti-sickling properties to the patient. This is still under trial. There are 2 clinical trials currently ongoing to test safety and efficacy of lentiglobin in patients with sickle cell disease. Hope? Yes, of course. This is my take-home message. New hope for sickle cell disease and new hope for our dear patients at the hematology clinic of Qasr Al Aini. Thank you.